pancreaticoduodenectomy question. Okay. Shall we go on to the next topic?
Yes, sir.
Please, Abhirami, you are presenting?
Yes, sir. Yes, sir.
Thyroid. Okay. Go ahead.
My topic is case presentation. 35-year-old female who has in front of neck, which is gradually increasing over the last 5 years, causing mild change in voice and difficulty in swallowing, posted for excision of swelling. A history of presenting illness. Patient was apparently normal 5 years ago, after which he developed a small swelling in front of neck, which is insidious in onset and gradually increasing in size, associated with difficulty in swallowing and change in voice, which moves with neglutation. No history of breathing difficulty, coughing, or choking sensation during lying down position. We should ask any history of pain over the swelling or recurrent fever or URI, and we should ask for any history of stridor, any sudden increase in size or hemoptysis. We should ask history of any loss or gain of weight, intolerance to heat or cold, and any history of constipation or diarrhea, any history of tremors, palpitation, increased anxiety, fatigue, and vision disturbances. Any history of headache, sweating, palpitations, and bone pain. Past history, we should ask any history of like routine past comorbidities like hypertension, diabetes, cardiac events, any malignancies, seizures, any history of drug allergies, any history of previous hospitalization, or any history of surgery or any radiations. Treatment history, should ask any history of regular medications. Family history, any history of thyroid illness running in the family, any other significant family history. Personal history, normal updated, mixed diet pattern, bowel and bladder habits will be normal. Normal sleep pattern or any history of sleep disturbances. Marital history, a normal vaginal delivery or a cesarean section, or any history of thyroid disease during pregnancy, non-consanguineous marriage or consanguineous marriage. Menstrual history, regular or irregular cycles, any history of amenorrhea, dysmenorrhea, or menorrhagia. And we should also assess the socio-economic status using modified Kupasamy score. Then going on to examination. Generally, the patient is general examination. Patient is conscious, oriented, moderately built, and nourished. We should check height, weight, BMI, any pallor, icterus, cyanosis, edema, lymph node enlargement, and we should check for whether skin is normal or not, and eye signs, any lid lag or one graphic sign, any lid lag is present, or Geoffroy's, wrinkling in the forehead, Stelwong, infrequent blinking, and Mobius sign, absence of convergence, and this. Then we should check vitals, temperature, pulse, BP, respiratory saturation, and we should also check for tremors on hands and tongue. Then airway examination, and should check for any gross facial dysmorphism, mouth opening, modified Mallampati grade, tongue, neck movements, dentitions, bilateral nasal passage, patent or not, and spine and palate, anything normal. Then going on to thyroid examination, inspection, patient examine sitting position with the head thrust backward against the hand clasped behind the occiput. We should check from front to side. Note the position, nature of the swelling, diffuse or localized, extent, size, shape, an overlying skin like dilated veins, any scars, signs of inflammation, anything. Then thyroid swelling moves upward on deglutition, and look for inferior border as the gland moves up and does not move with deglutition. Palpation. All inspectory findings should be confirmed and examined from front. Low border of swelling is palpable or not. Look for surface smooth and consistency, any like firm. Then overlying skin is fixed or not, and check for tracheal position like a finger insinuation test. And like carotid artery palpable or not. I need check for bruit. And then coaches test the presence of stridor on compression of the swelling. It causes stridor in case that is coaches test is positive. Then a percussion, any resonant or dull note. In case of retrosternal goiter, it would be dull. In auscultation, check for bruit. Then Other systemic examination which should check with will be normal limits. In a diagnosis, 35-year-old female presented with swelling in front of neck with pressure symptoms and without tracheal compression, with no retrosternal extension and no future suggestive of hypo or hyperthyroidism, with no known comorbidities, posted for existence of the swelling, probably thyroid swelling.
So you made a probable diagnosis of thyroid swelling because in the case scenario given, it is not given as a thyroid mass. Okay, it is a swelling gradually increasing in size in front of neck. Most of the time it is a thyroid swelling. But what are the other causes of the swelling in the front of the neck other than thyroid increase?
Lymph node enlargement, submental, subtracheal lymph node enlargement, subhyoid bursitis, thyroglossal cyst, laryngocele, tracheocele, midline
Cystic hygroma
lipomas.
happen?
Sir?
Have you heard of cystic hygroma?
Yes, sir. In children?
Common in children, but very rarely it can happen in adults also.
Yes, sir. Yes, sir. Ludwig's angina also.
Ludwig's angina. So all these things are, but how do you confirm that it is a thyroid swelling? You have examined the patient and now you say it is a probable thyroid swelling. Why do you, the conclusion, if you have examined and found out, can you not differentiate between the thyroid swelling and the other causes of swelling in front of the neck?
So long duration swelling with middle-aged female, probably benign, not a malignant.
Okay. So my question is, how do you differentiate the mass arising from thyroid from other differential diagnosed masses? What is the single test that tells you that it is only a thyroid swelling and not other causes of lymph node or
moves with deglutition?
Ultrasonic.
Deglutition.
Clinically, moves with deglutition. When they swallow, it produces a movement in the, that is the most important clinical test by which you diagnose. How do you do the test? You just ask the patient to swallow their own saliva and do the test, or
No,
how
sir.
to do the test?
You should give a sip of water to swallow.
And that time you just observe, or supposing you don't correctly see the movement, then what do you do? Will you say it is not a thyroid swelling? A huge thyroid, sometimes when you, even if you ask the patient to swallow water, it may not move because of the mass and the restricted space. So in that case, how do you know whether it is moving with deglutition or not? So I always palpate the gland. Okay, hold the gland from behind,
Yes.
and then ask the patient to swallow a sip of water. Definitely, you can feel the movement from your hand, even if it is not visible clearly. Okay, that is why you must do that deglutition test. You should not simply ask the patient to swallow and watch from front. Okay, right. Now the common questions in the exam you can expect in if you have a thyroid, definitely a thyroid case will be kept if it is available. The common questions are starting from embryology and anatomy. How do you, what is the extent and location of thyroid in the neck?
C5 to T1.
C5 to
T1.
T1, vertebral level. But front, what are all the structures it is occupying in the front of the neck?
Middle of the thyroid cartilage to fifth tracheal link, the extension will be there, sir.
Extension of the lobe. What about the isthmus?
Isthmus to fifth tracheal link.
Fourth,
No, second to fourth tracheal links.
Second to fourth tracheal link. What is the applied anatomy importance of this isthmus position?
Tracheostomy. In case of
when you do a tracheostomy, you have to do it below the fourth tracheal ring. Otherwise, you may injure the isthmus and that may cause a severe bleeding. Okay, so you must be careful when you do a tracheostomy. It is better to go below, see the fourth tracheal ring rather than doing it above.
Yes.
That is the important anatomical consideration for that. What is the blood supply to thyroid?
Superior thyroid artery is a branch of external carotid artery, supplies the upper pole. Middle thyroid artery is a branch of thyrocervical trunk, which is a part of subclavian artery and supply middle lobe. And inferior thyroid artery, which is a inferior thyroid artery.
What about the venous drainage?
Venous drainage, superior
Do you have
thyroid
three: superior, middle, and inferior for venous drainage also, or?
Yes, sir. Three.
Say. So, what is the clinical significance of this blood supply? Both artery and vein. So much of such a small gland, you have so much of arterial and blood supply, I mean venous blood drainage. What is important? Why this gland has got this much of blood supply?
Highly vascular.
Yeah, highly vascular because of the increased blood vessels. But why so much of blood is being given to this gland? What is important? At what age of the gestational age this gland starts developing? Embryological
21
age.
days.
21 days, that is 3 weeks. And reaches its normal position at what month of, or how many weeks of gestation it comes to become active?
7 weeks.
7 weeks. So what is why it should become active at such a small gestational age?
It is the first endocrine gland.
What is the importance of its activity? The thyroxine that is being secreted by this endocrine gland.
Growth and development.
Growth and development of which system?
Central nervous system.
Central nervous system is very, very, that is why if you don't have adequate thyroxine, what will be the baby born as?
Fetal hypothyroidism.
Cretin. Okay, cretinism will be there. So central nervous system and the overall body growth is very important function of thyroxine only. So that is why it is having such a rich blood supply. And this blood supply, what is the complication it can produce if you do a surgery because of such rich vascular supply to that both artery and venous system? What is the surgical complication which is common in the immediate and late post-op period?
Hematoma formation.
Hematoma, hemorrhage and hematoma formation. Okay, so that is the reason why the surgeon has to be very, very careful in securing good hemostasis when they do the surgery. What other structure can be commonly injured when they try to do hemostasis, when they try to do dissect and resect thyroid? What other structure can be commonly injured?
Recurrent laryngeal injury.
Nerve injury, recurrent laryngeal nerve injury. Okay, so that is the, what is the risk of nerve injury? What can happen if there is, what are the types of nerve injuries that can happen, but it's iatrogenically caused by the surgery?
Like partial or complete.
Complete. How many recurrent laryngeal nerves are there?
2, sir.
Bilateral, right and left are there, no? Can it be a unilateral or bilateral injury? Okay, supposing they do a total thyroidectomy, it can be a bilateral recurrent laryngeal nerve injury, and this can be total or partial injury. Okay. So the nerve, this is a common theory question they ask you. Types of recurrent laryngeal nerve injuries. It can be unilateral, partial, unilateral, complete. It can be bilateral, partial, bilateral, complete. What is the difference between each type of injury?
In a unilateral partial.
Supposing you have a right side, they are doing a hemithyroidectomy on the right side. And unfortunately, right recurrent laryngeal nerve has been partly injured. What will happen to the patient?
Abductors will be affected.
No, what will be the clinical scenario if there is a unilateral partial recurrent laryngeal nerve injury? As soon as you extubate, the patient is fully awake, surgery is over, no bleeding, nothing, patient is breathing adequately, motor power is normal, and you extubate the patient, because you cannot find out until you extubate whether there is any injury or not, isn't it? So in that case, what will be the presenting feature of a unilateral partial recurrent laryngeal nerve?
Change in voice.
It will be just hoarseness or change in voice. Patient will not have any other difficulty in breathing or anything. Supposing it is a complete injury on one side, unilateral.
Strider.
You will have early stridor, but patient will continue to breathe normally and get compensated by the activity of the other side. And that will also will not produce a great problem. Which is the most dangerous injury? Life-threatening injury of nerve injury after thyroid surgery.
Bilateral superior laryngeal and recurrent laryngeal nerve injury.
We are asking only about recurrent laryngeal nerve.
Bilateral complete.
Complete, is it the most dangerous? Complete means
Partial.
patient, the vocal cord will come to cadaveric position. There is still an opening.
Yes, sir.
So bilateral partial injury is the most dangerous because the adductors will be acting, abductors will be paralyzed. So vocal cords cannot separate. So that will come into the midline and there will be severe occlusion, laryngeal occlusion will happen and patient cannot breathe. So it is a life-threatening emergency where here we have to restore the airway. So what will you do if you, supposing you extubate, it is a total thyroidectomy case. Surgeon has partially injured both the recurrent laryngeal nerves. And as soon as you extubate, patient makes a sound and then completely chokes. There is no breathing attempt. There is indrawing in the suprasternal notch, indrawing of the intercostal, everything indicating there is a severe occlusion. What will you do?
We can re-intubate or emergency tracheotomy.
With both the vocal cords in midline, is it easy to intubate?
No, sir.
Emergency tracheostomy.
Any other easier, small, quick method to open up that airway? Any drug you can give to paralyze and remove that adduction of the vocal cords?
Sucks.
Can't you give saxamethonium?
Yes.
Saxamethonium can be given, which will paralyze those muscles also and open up the cord, and then you can put the. So tracheostomy is going to take time, or even a trachothyroid puncture and ventilation all are going to take time. And once you give saxa and re-intubate the patient, we can do an elective tracheostomy very conveniently, leisurely, without any rush. Okay. So that is the answer that we have to give. Bilateral partial recurrent laryngeal nerve injury is the most dangerous life-threatening complication after thyroid surgery, where vocal cords will come into adduction because of the absence of abductor. Bilateral abductor palsy will happen. So the vocal cords will meet in the midline and occlude the airway. Immediate treatment, you can push in a dose of saxamethonium, paralyze and ventilate and re-intubate the patient and do a tracheostomy later. That is the answer that we are expected to give in this case. Right. So the other common questions are, supposing you do this surgery and you want to preserve laryngeal nerve function or monitor laryngeal nerve function intraoperatively, what is the current technique that is available?
That EMG endotracheal tube, with that we can monitor.
Fantastic. You can use a EMG endotracheal tube. So have you ever seen or the tube or the procedure that is being done?
No, sir.
Not seen that. Okay. So that is a current method of identifying to prevent this complication of recurrent laryngeal nerve injury. Supposing there is a retrosternal extension, what are the precautions you will have to take when the patient is posted for thyroid surgery?
We should have an assistant while induction. In case of any collapse after induction, we can ask the surgeon to lift the like assistant to lift the
So
tumor.
that is a huge thyroid pressing on the trachea. What you are talking about is for a huge tracheal swelling, which is compressing and then causing an obstruction in the tracheal level outside the thorax. My
Yes,
question is, supposing there is an intrathoracic retrosternal extension, then
Yes,
what are the precautions you have to take? In that case, you cannot pull out that retrosternal portion by
we
asking the surgeon to pull.
yes, sir.
What you are saying is only for a huge thyroid.
Large thyroid, yes, sir.
And in huge thyroid already causing compression, what will be the patient's complaint? If you elicit the history, which
Pressure
will give you
symptoms
a
will
clue
be
that
there, sir.
there is a obstruction.
Pressure
Patient will
symptoms will
not
be
be
there.
able to lie in the supine posture.
Yes,
So
sir.
they will always turn to one side and lie on the right or left lateral to avoid the compression, mechanical compression by the huge gland. So in all long-standing huge thyroid swellings, you must ask the patient, are you comfortable lying supine position? Then they will come out with the answer that no, sir, I am not able to lie. I always lie on my side to avoid, otherwise I get choked. If
Yes,
that
sir.
is the question, that is the history that you get, what pre-op investigation is very important. The huge thyroid gland, where patient says they are not able to lie supine and they adopt a lateral position for the sleeping hours during the night or any time.
Yes,
What
sir.
is the important pre-operative testing that you must do?
PFT, flow volume loop.
Hmm.
Then X-ray neck AP lateral view to see
Okay,
tracheal compression.
all those things will only tell you whether there is an obstruction or not.
Yes, sir.
More than that, what is the one complication you are worried about in such cases after surgery? Supposing a huge thyroid surgeon plans to do a total excision.
Tracheomalacia.
Tracheomalacia, that will cause a complete collapse. So is there any way to identify the tracheomalacia preoperatively?
Bronchoscopy, which were
That is the answer. You have to do a bronchoscopy and try to see whether the vocal cord, I mean the trachea wall is already in a partially collapsed state or not. Okay,
yes, sir.
and you can find the consistency of the tracheal rings also. Normally,
And
tracheal rings
ultrasound.
will give a hard feeling when you try to rotate the trachea, the bronchoscopic tip and slide them through that, it will give you a slight hard feeling. Whereas in tracheomalacia cases, it will be all very soft. You will not feel that resistance as you are doing. So that is a very important test that you have to do.
Yes, sir.
And in retrosternal goiter also, you have to do a preoperative bronchoscopic examination to find
Yes,
out whether there is a compression below the sternal level
yes, sir.
and whether the endotracheal tube can be passed up to the carina, just about the carina or not. That is a very important pre-op testing that you have to do.
Yes, sir.
And if excision of that retrosternal goiter is also planned, what are all the approaches?
Three approaches, sir. Cervical incision, manubrio,tomy, sternotomy.
Sternotomy are the three important things. So if it is manubrio,tomy or sternotomy, what are the other associated risks that are involved?
Sir, other associated?
Surgical complications. What complications can happen if the surgeon has to do a manubrio,tomy or a sternotomy? What other complications of surgery can happen?
Increase of bleeding and other vital structure injuries.
Very good. So retrosternal goiter, what are the types or classifications that are available?
Depending on the extension, above aortic arch, between aortic arch and pericardium, and below the right atrium. Grade
Below
1,
the,
2, 3.
very good. So these structures are all very close by. Okay. So you have to, is it possible to do it by video assisted thoracoscopy or mediastenoscopy?
Yes, sir. Now it's available to do.
Available. So instead of open, patient sometimes can be operated for retrosternal goiter by a technique called mediastinoscopy also. So that requires a good discussion and consultation with the surgeon to decide about the anesthesia plan. What type of endotracheal tube you will prefer to use for thyroid surgery?
Flexometallic tube, North Pole ray tube, or this EMG tube, sir.
EMG tube, very good. So, what are the immediate post-op complications, delayed post-op complications after thyroid surgery, which will require help from the anesthetist?
Immediate like respiratory distress, the causes include a hematoma formation, rectal laryngeal nerve injury, tracheomalacia, laryngeal edema.
Okay. Delayed complication?
Delayed complication, hypocalcemia, bleeding, nerve
Okay.
injuries. Yes, sir.
What is the management of hypocalcemia?
10
What are
ml.
the features? How do you first of all diagnose the patient has developed hypocalcemia? What are the clinical features and what is the management?
Perioral numbness will be there, sir, and
Okay.
Drosh sign and Chavatsky signs will be there. Carpopedal spasm will be there.
Okay, that
He'll
can be
give
elicited, not
elicited.
but you have to elicit, not it will not be automatically present. You have to elicit them.
Tap.
So how do you elicit them? How do you
We
do
should
the
tap
obstruction?
the
How do you do
facial
the
muscle.
facial muscle? What facial muscle?
We should tap near. We should tap near the parotid gland. The facial nerves get irritated, and it will be shown. In case of Droscher sign, the BP cuff will be inflated, and the sign.
So you can see the fingers going into spasm. Okay, once you raise the BP cuff pressure, automatically the hand goes into spasm, which is called the carpopedal spasm. Very good. So if both are positive, what is the risk of not treating that? What can happen if it is not directly identified and treated?
Not treated.
Hypocalcemia, clinically diagnosed with your Chopstock-Stein and Trousseau-Stein, the patient complaining of perioral numbness. If you don't treat it immediately, what can happen? What is the risk of hypocalcemia?
Myocardial depression.
Myocardial depression. Calcium is important both for skeletal muscle as well as smooth muscle activities, isn't it? So all these muscles will start not functioning correctly.
Weakness.
So patient will have severe weakness. Even cardiac function also will deteriorate and has to be corrected as soon as possible. So how do you treat that?
10 ml of 10% over IV over slow 10 minutes.
Okay. Supposing it is recurring again after you have given this IV gluconate also, it is recurring. Is there any continued treatment required?
No, sir, within 24 hours it will settle, sir.
It will settle down. Supposing patient, all the parathyroid glands have been removed in total thyroidectomy, will it settle down in 24 hours? So you have to differentiate whether patient has total parathyroidectomy also done. Okay. So in that case, you will require continued calcium supplementation orally also. Okay, it is not that just one dose of calcium gluconate will not be sufficient. You have to continue it for lifelong. You will require calcium supplementation.
Yes, sir.
So these are the common questions that are asked. So we just see presentation to